Hello, welcome to the Champions Pulse, the official podcast series of Sickle Cell Foundation Nigeria, where we dive into everything that you should know and probably didn't know about sickle cell disorder. My name is Inakome Oka-Avai, and I'm super excited to be your host on this episode. And we've had quite interesting conversations in previous episodes, and we really just want to, touch on something that is very critical with the condition, and that's the complication. And to dissect this episode with me, I have once again our amiable and delectable Dr. Annette Akinsete, our return guest. Thank you for coming again, ma'am.
Thank you very much, Inakome. I'm always pleased to be here. Always.
Thank you. So we'll just dive right into it.
Mm-hmm.
In previous episodes, I know you mentioned some complications like stroke.
Mm-hmm.
Possibly stroke in children. Yes. And I think it's something that really needs to be talked about. People really need to know, what can happen, what can go wrong with this disorder. So let us into the world of the complications.
Yes, good. Let's pick up from that stroke that we had mentioned already. People find it difficult to understand, even believe that a child would have stroke.
That's a devastating thing to even imagine.
And it's something that's really best prevented. Stroke is best prevented anywhere, anytime, in anyone, but particularly with sickle cell disorder, especially because it's happening to children.
Yes,
so
exactly.
In fact, in medical school, we're told that when you see stroke in a child, invariably that child has sickle cell disorder.
So it's something that's very,
Yes, you're not likely to find stroke in a child. How long have they lived that the vessels will become,
Exactly.
So there, the thing about stroke with sickle cell is this. It can be picked up. They have what we call mini strokes, even before the big stroke occurs. Mini strokes. And how might you recognize that? Do you know who picks them up first?
I'd like to know.
The teachers in school.
Oh, so is it like they pick up symptoms?
Yes, the teachers. You know why? A child who's been writing legibly, good writing, handwriting, suddenly begins to scroll.
Oh.
The writing is now, like
blurry,
a crawl or scribbling down and up. And, something you might dismiss normally, or maybe hit the child and say, come on, write properly.
Maybe you're not paying attention. Or
that kind of thing.
Yeah.
But that is a red flag. That is a red flag. And that tends to be because a stroke has occurred. And what is a stroke? The vessels in the brain have been compromised, mostly by clots, blockage. So that may just be a first symptom. It may ease because blood flow will be reestablished, and that may ease because brain damage has not occurred.
So if I get you right,
we call them mini strokes.
It means that the child has a possibility to get into a stroke and come out of it.
When they are mini strokes, when they're tiny stroke, tiny blood vessels are blocked or narrowly occluded.
That's a lot for a child to go through.
I'm telling you, but the good thing is if you recognize that early, you intervene. And how do you intervene? By doing what we call extreme blood transfusion. That is, you take out a lot of the sickle cells and replace with AA cells. And when you do that a number of times, invariably that's the stroke.
The tendency to have a stroke reduces.
Yeah. Exactly. But remember that what we do in our center is in a stroke prevention unit is to have that TCD scan and determine those children who are at risk of developing stroke. And how do you know? By just watching the tracing on the computer, and then is the velocity of the blood in the big vessels of the brain. That's what the probe is looking at, if you like. So the technicians know what to watch on their computer screen to see the tracings, and they're able to pick up those children who are at high risk for stroke. Anybody in the world is at some risk. So there's something called the standard risk. So at the general population, we're all at risk.
Even normal people?
Even children. Yes, everybody's at risk of one thing and the other. So you can't say no risk. That's the thing about medicine. It's not physics, it's not math.
So it's low risk and high risk.
You can say low risk, standard risk. That is like the general population. And then high risk. That high risk is what we focus on. We pull them out and place them on what we call preventative treatment. Now we even have hydroxyurea. Hydroxyurea in many ways can replace extreme blood transfusion.
Okay.
So that's for, like treating the stroke. But I want to just say what happens to the family. The family is devastated.
I can imagine.
It's just best prevented.
Yes.
That's just the
even
thing
for
about
an
stroke.
adult, it's
just the dynamics of the family changes. It just changes. So it's best that big stroke never occurs. So the thing is, if we find the tiny strokes occurring, those mini strokes, prevent them. And when a big stroke has occurred, you can also prevent subsequent strokes by making sure the child is on hydroxyurea or on extreme blood transfusion. In other words, under the care of a hematologist as much as possible. And in other words, again, that tells us that sickle cell disorder is not a disorder you treat in primary healthcare centers. In general hospitals to some extent, but definitely where you have a specialist. Again, so that's important. That's stroke. And like I said, any condition that affects the blood, the blood goes everywhere, so all the organs come. Yeah. And now that we're seeing patients in their older decades, we're seeing more complications that affect the lungs. That's what we call pulmonary hypertension. And that's something that the academicians, the doctors in academia are beginning to research into.
This is different from the normal hypertension.
Yes, this is the pressure within the circulation of the lungs, because there are two circulations in the body. There's the pulmonary circulation, the one that goes from the heart to the lungs, and then the one from the heart to the rest of the body.
Right.
Okay, so that is the usual hypertension. Pulmonary hypertension, of course, is fraught with other complications that also in the end affect the heart. So it's something we're seeing now more and more in the 4th, 5th decades of life for patients who are not properly controlled. And that tells you that if you dial back and they have early diagnosis and prompt effective treatment over time, that the patient will do well, and they can, I say again and again, they can live a normal life and they can contribute meaningfully to their communities. So think of the brain. Yes, that's where stroke occurs. Think of the heart. They have heart issues. Whether it's heart failure or a heart attack. When there's a clot, the clot can clog the vessels. As a medical student, one thing I remember was the vessels that supply the heart.
Yeah.
Not the big ones, not the aorta that comes out of the heart to the rest of the body.
The smaller vessels.
The ones that actually feed the heart. The coronaries. They're tiny.
Yeah.
And I just said to myself, what kind of architecture is this? I just said,
how those tiny vessels are carrying such pressure?
I must not question God. Because I thought for a heart that is so important that the vessels that supply it must be big as well. But the hearts, the big vessels that come out of the heart do not supply the heart directly.
Yeah.
They just supply the rest of the body. The aorta goes down and branches out everywhere else. But then the tiny coronaries are the ones that bring blood to supply the musculature of the heart. So, but those ones now can be easily clogged with clots. And that's when you have a heart attack or cardiac arrest. Not heart failure. Heart failure is a different thing. Heart failure is you can also get it in sickle cell. It is when the heart is like weak muscle of the heart. That is heart failure, and that happens over time. A heart attack, like as I said, a cardiac arrest is sudden. You can also get a complication in sickle cell. Heart attack, heart failure, pulmonary embolism, pulmonary hypertension, stroke, renal failure, acute renal failure,
with the
chronic renal failure, kidney failures. Then, of course, we talked of leg ulcers. So think of all the organs of the body. And then the one that tends to be sensitive is priapism in men. Priapism, that bothers me, because when you see a young man, sometimes young men, sometimes not so young, walk through your doors and they're averting your gaze. They don't want to catch you. There's something they're hiding. Yeah. And invariably,
that's something very personal. Yes. Sensitive.
And they may not tell you about it, as they just sit down and say, oh, I have pain, I have crisis, I have this, I have that. They won't say anything. And so you have to now ask, what about priapism? Do you have painful erections? And that's not sexually related. And I say, yes, doctor. So
and I heard we need to for months.
You can maybe not at a stretch, but initially maybe a few minutes, then sometimes hours.
Wow.
Sometimes days, and then you wonder, how do you prevent it? Again, everything in sickle cell is manage the condition. When you manage the condition, it's same pathophysiology, that pathology of blockage of vessels. Now the penile vessels are such that they're like fingers, like end. It's an end organ. Blood will flow in, and not return.
Okay.
You need to, the penis is such that blood goes in and it should come
out.
So in sexual activity, and blood flows into the penis, it's turgid, it's rigid, and after the sexual performance, it relaxes.
Yeah,
blood flows
out.
back out, and that's how it should work. It should never remain rigid for long. As one of the long-term complications is flaccidity and impotence. And no young man, no
eventual,
man,
so it's
no
two
man
extremes.
They can have impotence, and that means they can no longer perform sexually, and no man wants to have a complication. So it's best prevented, and the only way to prevent it is take care of the condition itself. Just simple water, lots of water. Take your medication, prevent infection. That basic treatment. Those are the things that prevent complications like this. This is one of the worst complications that happen.
I agree. I mean, I agree totally.
And we're speaking earlier about persons who have sickle cell disorder and the kind of emotional and mental strains they go through. Anybody who has priapism definitely will have one of the patients we're evaluating is an older person in his 30s. He's had priapism, and I know that's contributory to the depression we're seeing. In this person. He hasn't come in yet. We're planning that he'll come in for the
that's quite a lot. So while I agree that priapism is one of the most terrible,
it may not be life-threatening,
but I mean to live
quality
with,
of life,
yes. That's a very terrible complication to live with. But I'm also I have this emotional, I want to be very I mean, stroke in children is something that I would also consider a lot. I understand that we can check it and prevent it. How often would you advise parents who have children with sickle cell disorder to keep tabs on this so that we don't have the
for which strokes? One now, the stroke or the stroke? Yeah. Stroke, definitely. We already have that because from literature, and research, we have found that children between stroke in sickle cell occurs more in children between the ages of 2 and 16.
Okay.
So in that cohort, in that age group, any child with sickle cell in that age group must be brought for transcranial Doppler
so scan. Is it monthly, yearly, weekly?
Once you detect that it's high risk, you must take action. That is referred quickly to a patient, to a doctor, a hematologist, and they do the extreme blood transfusion or place the patient on hydroxyurea. If it's standard risk, it's just like everybody else in the population, come back in 6 months. So we keep checking. And they check again and again. They come back in 1 year. Because the risk now reduces when the child is over 16. The risk of stroke reduces when the child is over the age of 16.
So the higher the risk, the more frequent you should come in for.
No, the higher the yes, definitely. Yeah. You start treatment and still return every 3 months to check whether the risk is still high. So that is for stroke. Now, I wish there was such a thing for priapism to also prevent priapism. But it's just that there isn't. And the way to prevent it is take care of the condition itself. The basic treatment, early diagnosis, prompt and effective treatment. And that's through the medicines that we take every day.
So we've talked about stroke in children, which is a very devastating complication that I must say.
In children,
and then we've talked about priapism, which is another devastating complications for adult males, unfortunately.
Yes.
And then
children, even children get it. Yes,
priapism.
They and it's painful. Its definition of priapism is painful erection of the penis that is not sexually related. That is not due to sexual stimulus. Yes. And it just stays on for a long time. And the longer it stays, the more painful and the more the risk of impotence developing. So the only way to prevent that is to be sure that you take care of the condition. However, how about managing it? That's okay. Sometimes I don't think we have enough research. However, sitting in warm water, as they've been told,
can help relieve.
Cycling and walking up and down the steps.
Even with the pain.
Because, it tends to increase
blood circulation. Okay.
And that tells, obviously, of course, you take pain medication. To ease the pain. But that's how you now manage it. But when it gets so bad and the patient cannot be helped by these conservative management and medication, doctors have resorted to surgery. Or even before the surgery, because there's not much that's been done in the area of research to bring us to a point where we know we can deal with Priapism properly. But there's something they call needling, where they insert a needle in the pin, in the vessel, the penis, and draw the blood. And what's the whole point? The point is to reduce, to pull out the blood and reduce the pressure. And okay, by the time it gets there, the patient is quite bad. Then the worst is the highest level of intervention would be the surgery, where they actually do like a shunt. They intervene, suture, and establish a kind of communication between the vessels. Okay, so again, by the time they do that, impotence is actually already already supervened. So it's best prevented. If it's not preventable, these are the things that can be done. Professor Akinsete was doing some research into the use of a common medication we use for asthma, salbutamol, that we call Ventolin. And but it's long, the one that's long acting. Okay. So you could see that it was providing a level of relief for the patients, and some people still use it. I'm just hoping that we in the center now can work on that and bring publish papers on that. It would
be absolutely amazing. I mean,
and because it's simple medication, inexpensive, and if you can take it and prevent, to help prevent the Priapism from occurring, that will really help. Yes.
The more management measures that we have, the better. So
exactly. So I know we need more research.
Yeah, we do. So besides this, I mean, this is a lot already. I mean, for one day to even learn, I'm sure that, I mean, these are things that
we didn't even talk about the eye, blindness.
Wow.
And the thing about blindness is to remember that it's more common in persons with SC, not SS.
The SC
as much as we already say that SS is a more severe manifestation of sickle cell disorder, but SC, even though not as severe in terms of crisis, in fact, like SC, some women don't get to know except when they get into pregnancy. It's in pregnancy they begin to have symptoms.
Right.
But eye problems and blindness,
so
retinopathy,
let me get this
more
straight.
common in
so for those who
SC.
have SS, they are more prone to the actual crisis.
Yes,
those who have
disease.
the SC don't exactly exhibit crisis, but
they do, but not as much,
blindness,
not as frequently, but it's not a severe disease. That's just a way to describe it. Except, of course, that retinopathy, that is in the back of the eye, the nerves at the back of the eye, which is just like part of the brain, really, is more common in persons with SC. So they must have eye tests every year, at least once a year. So you see why over and over again we must emphasize that the care must be multidisciplinary.
Exactly, multifaceted. And it almost feels like people with this condition you don't wait to feel something before you go to the facility.
It. That's on the nose.
You don't wait to feel sick. It has to be routine. You have to keep tabs on yourself regularly.
Absolutely. One of the doctors that was talking to our patients and I said because young people don't like wasting time to see the doctor.
And I mean,
said, just come, just say, hey doctor, I'm fine, bye, hi, bye, I'm fine today, that kind of thing. But just show up every 6 months, whether you're well or ill or not. Just show up. I said, stand there and say, hey doctor, I'm fine, bye.
Actually, I mean, that's something we should actually hammer on, because we always wait to feel something before we feel the need to visit the doctor.
And then I'm glad with technology now we can follow up our patients much better than we did in the past. Just to check on them. That's really so. Think of any part of the body can be affected by sickle cell disorder.
That's actually scary, but I'm glad that we are, touching points on this particular topic, because a lot of people just think that sickle cell disorder is you fall sick. You're just sick all the time. It's really amazing to see that it goes beyond the surface, and people can actually feel these things, and it just it can affect your entire life from top to bottom.
Which is why I understand where our legislators are coming from when they say, they want to penalize anybody who's a carrier, who has a child with a carrier. So, but we're working with them as I speak now. We're looking at some bills.
But
right now that will become laws. Pardon me?
You think that's possible to
penalize?
Yeah.
No, they shouldn't. We pushed back. We pushed back on that already, because they did come up with bills that were punitive. That said, if you're AS and you married AS, you'd pay a fine of, I think, 20 million naira.
Really?
Or you go to jail for 10 years.
Really?
Yes.
I'm honestly sure
So
that
that's
people who would,
that would push
stand.
back. Of course, the NMA, no, that's us, NMA is doctor. NBA, is that what they're called? The Bar
lawyers,
Association.
yes. Nigeria Bar
The
Association.
pushback, of course, is not in your place.
I think that's even going to bring us to another level of problems with people.
But we are saying that, but it's still happening. That's at the national level. But you know that the subnationals have come up with their own laws, and they're not even listening to anybody. NBA.
So
there's some states in Nigeria now
for that.
We haven't seen the law implemented. That's one thing. It's easy for you to come up with a law, but is it implementable? You know, so laws are meant for man, not man for law. You have to make it implementable. And again, one of the conversations we're having with them right now at the National Assembly is you don't shave the heads of people when they're not there. So there's in global speak these days, we talk about the lived experience. Persons with a lived experience, they need to have a seat at the table.
They do.
So we have insisted that bill that's being discussed right now should not see the light of day until we've brought in persons who have the condition. You know, so and that really came from the disability space. In Latin they call it nihil. They say nihil de nobis, sine nobis. Nihil de nobis, sine nobis. Nothing about us without us. We have to be there to guide you to. So they need to talk with stakeholders to determine how best to move forward.
Because I feel like if we're going to have that kind of law in place, then we also have to do something about wrong genotype testing.
Fantastic.
Because I've had people who are very intentional about their genotypes get into marriage and they find out that even with all intentionality we still have wrong genotypes. So would you prosecute those kind of people? Because obviously it wasn't their fault.
That's regulation. Exactly. And that is government. That is government's job. Government needs to be sure they're regulating our laboratories, our medical laboratories. We've talked about it over the years and we'll keep talking about it, but I'm sure I just want to ensure I want government to ensure that this happens. How they're going to do it? They have the wherewithal. They have the resources. We have the people in Nigeria, so we have the agencies that should be able to do that for us. So that's so important. Inaccurate diagnosis is one of the banes of sickle cell management. And control in Nigeria.
Okay, that's quite a bit of a conversation you have there. We've talked about stroke just to, bring it home, like I always say.
Yes.
We've talked about stroke in children, Priapism. You mentioned leg ulcers, and we talked about retinopathy.
Yes,
for people for people who are of the SC genotype and prone to blindness. And then basically, this condition can affect any organ in the body.
Absolutely.
As long as, because it's a blood disorder.
And the blood goes everywhere in the body.
Exactly, the blood goes everywhere. Right. So, just to wrap up, just to package all of this information, package it together, and then deliver it as one theme, so that listeners and everyone at home hearing the sound of our voice can just take one thing home today. What's that one thing that you like to just use as an envelope for this conversation today?
Okay, it's just to say that sickle cell disorder. We know it's not a stroll in the park. It's not easy to live with. Yeah. Okay. But it can be managed. Sickle cell disorder can be managed, and when it's properly managed, when it's detected early, and we intervene early, early treatment and effective treatment, persons with this condition can live normal, productive lives, and they can contribute meaningfully to their communities. We talked about complications. There are so many complications for a condition that's in the blood. Any organ in the body can be affected, from the top of the head to the tip of your toe. So from stroke in the brain to blindness at the back of the eyes, deafness. We never mentioned deafness.
Really?
Deafness, yes.
We have that
respiratory conditions, heart attack, heart failure. We talked about pulmonary hypertension, hypertension in the lungs and lung system. Renal failure, that is the kidneys. That can be acute or it can be chronic. Acute being that it's happening suddenly. Chronic means that it's just a disease going over time. Then and I was going from the top of the head to the tip of the toes. Now we can go down. We talked about priapism, the genital organs. What was the priapism in women or in men? Okay. But what about the women? There's also sexual problems around the women in terms of pregnancies. We say, can they have babies? They advise, because most women will aspire to have children of their own. So, but they're advised not to have more than 2 children. Easier said than done. What if they've tried and they've had too many miscarriages?
Yeah.
Those are pregnancies that you must count. So are you going to say, okay, 2 pregnancies? So there, the jury is still out. We don't know how best to advise persons who have sickle cell, who
would want to have more children.
Mothers, who want to have be mothers and have children of their own. It's difficult, okay?
Yeah.
But it is there. We have to note that. I think at one of our earlier programs, I said, when you're looking after them from childhood, you begin to think that this child will one day want to become a mother.
Yeah.
To be sure that you prepare her for that pregnancy. She doesn't go into pregnancy with anemia and so on.
I think that's a whole conversation on
altogether. So there, I'll end with leg ulcers.
Okay.
Leg ulcers are the most debilitating and stigmatizing because these ulcers smell. They don't heal. They go on for months and years, and it makes you withdraw. That's where I end with this girl. For me, that's a beautiful name, but who refused to respond to her name, and she responded to Elebulese. Elebulese in Yoruba means the one with the sore on the leg.
She would prefer to be called that.
She didn't prefer. That's what she was called. And if she had that Elebulese, she would respond.
Oh, wow.
But if she was called, for me, she wouldn't respond. She had forgotten her name. And then this girl became suicidal. So you can imagine the problems are not just physical, they are mental, they are emotional. Remember that WHO says that health is complete well-being, physical, mental, and emotional. And now we even add a spiritual dimension. So all of that are affected in the person with sickle cell disease, sickle cell disorder.
All right. I think that's a very good point to wrap up this conversation. So there you have it. Sickle cell disorder is a lot. In fact, I'm just going to wrap it up as that. It is a lot. It goes beyond the pain. It goes beyond the crisis. It goes beyond just what you see physically. So thank you very much, ma'am, for being on this show with us.
I'm glad I'm here.
And
there's a lot to talk about.
There's a lot to talk about. And we look forward to having you in the future again to talk about more salient issues regarding sickle cell disorder. Thank you very much for joining us on today's episode. I believe strongly that you have learned a whole lot because I've been wowed myself. And until you join us next time, don't forget to be kind, stay informed, and also share this episode with someone who you think might need it. Thank you. See you next time.